Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today.
There is research on tongue tie, and since 2000, the number of published research studies has incrementally increased every year. So that's a good thing. That's telling us that more people are studying it, more people are interested in it, and more researchers are noticing the importance of getting some better data out there.
You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Palladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Hello, everyone, and welcome back to the Tongue Tie Experts podcast. I'm your host, Lisa Palladino, and today I have a special guest, Dr. Rebecca Hill. Dr. Hill earned her BSN from the University of Rhode Island, her MSN and Postmaster's Certificate in Nursing Education and Doctor of Nursing Practice from Duke University, and her PhD in nursing from Boston College. She is a family nurse practitioner, certified as a nurse educator and lactation counselor. She mentors nursing students interested in research and has co-authored many publications with her students. Rebecca currently serves as the Associate Dean for Academic Affairs and Associate Professor at the MGH Institute of Health Professions School of Nursing in Boston, Massachusetts, and maintains a clinical practice. I'm getting tired just reading this. She's an active member of several professional organizations, including the American Nurses Association, American Association of Nurse Practitioners, the National League for Nursing, and the International Consortium of Ankylofrenula Professionals. She's an active member of the Expert Panel for Breastfeeding as a fellow of the American Academy of Nursing. Dr. Hill's research focuses on the advancement of the state of the science surrounding tongue tie and its associated sequelae on infant feeding. That's why you're here, Dr. Hill. Thank you so much. She is current grant funding from the Gerber Foundation examining the mechanics of breastfeeding for infants with tongue tie before and after frenotomy. So thank you, Dr. Hill, for being here. I'm very excited to have this conversation. And is there anything you'd like to add to that magnificent bio that I just read?
No, Lisa. First, thanks for having me, and please call me Rebecca. Nothing
Okay.
else to add. I think that's enough.
Yeah. So the reason why I want to just keep saying doctor is because, I started out as an RN, and it was way back in the 80s when I graduated. It was an associate's degree, and there has been so much advancement in nursing practice, and I think that it's vital for other professionals to recognize, people like you who have gone on and worked and studied to achieve doctorate level. And you have a PhD, you have a double doctorate,
I
right?
do. Yes,
Right.
I'm
I mean,
a
so we could go to
lifelong
medical
student.
school and get one, that's almost easier than the path that most nurses take to their doctorate. So, I honor that and respect that. And thank you for, without even talking about the tongue tie stuff, thank you for what you've done for the nursing profession, because everyone who does that is elevating our profession just a little bit more.
Absolutely, we need more doctorally prepared nurses. So
Yeah,
yeah,
yeah. Yeah, it's great. I was like on the fence about it. I had a professor who was trying to talk me into, after my master's, staying off my doctorate. And at the time I was working at the hospital, I was like, nobody's going to care
yeah.
in my role if I have a doctorate. Like, it was very frustrating to me, but that was honestly the truth. Maybe in my retirement I'll go that direction.
It's a big commitment, but
Yeah,
learning is never a wrong decision, I guess.
that's a great way to put it. So I want to use this conversation to, let's just say, quiet some people's talk about the fact that what we hear all the time is there's no research about tongue tie, right? So give me your feelings about that, because there is research on tongue
Yes,
tie.
there is. There is research on tongue tie. And since, 2000, the number of published research studies has incrementally increased every year. So that's a good thing. That's telling us that more people are studying it, more people are interested in it, and more researchers are noticing the importance of getting some better data out there. So, a lot of the research that's out there is in smaller samples, has smaller sample sizes, which is okay. I think you have to start somewhere. We do have 5 randomized controlled trials that are published out there, not a lot. So if you see a lot of the critique about the research out there, a lot of people are saying, well, there's not a lot of randomized controlled trials out there on this population, but
Mm-hmm.
that's really hard to do.
Mm-hmm.
So a randomized control trial means that you are randomly, blindly allocating part of the sample to an intervention. So if we're talking about tongue tie, the intervention is likely frenotomy, right? And
Mm-hmm.
randomly, blindly allocating another part of your sample to not receive that intervention. So that's
So that's like denying care that might
right.
be
Yeah.
needed
And
and testing if it,
yeah, and
yeah. Yeah.
ethically,
So it's
that's
hard.
hard, right? Because we're
Yeah.
talking about a really fragile dyad, mother, babies, that whether or not they're breastfeeding, they still need to eat in some capacity. So,
Mm-hmm.
withholding treatment, if we think that it's the tongue tie that's causing an issue with feeding or growth or significant pain for the breastfeeding parent, it's really difficult and unethical to withhold treatment if that is the reason that the baby's not growing or the mother is not able to breastfeed, and that's really what she wants to do.
Mm-hmm. Yeah, absolutely. And you brought up a good point in passing there. This isn't just about breastfeeding. This could be about bottle feeding as
Right.
well, right? So if you have a baby who can't feed, you're not going to randomly assign them to a non-treatment arm. That could be
Right.
dangerous,
Yeah,
right?
of course.
So do you typically let patients kind of self-select? Like, would you say there's some families that don't want a procedure,
Right.
right? Like, if things are borderline and the baby, can eat in some way, I mean, I have people who come to my office and say, I want to optimize things, but there is no way my baby's going to have a procedure.
Right.
So, like, I would imagine that could be helpful.
Yes, absolutely. It's just no longer considered, a randomized clinical trial, but
Right,
that's
right,
okay.
right,
It
right.
doesn't have to be an RCT to be a good quality study. But
Good point.
that's
Good
one of
point.
the
Yeah,
limitations for, studying
yeah.
this population. And also one of the things that will continue to receive that critique is, well, this isn't a double-blind randomized controlled
Right,
trial, which
right, right.
it's fine. It doesn't have to be. But then that leads you to another question of, for the groups of dyads or parents and their infants that don't want to have the procedure and they're feeding okay, well, then what brought them to your office, right? And
Good
what can we
point. Right,
study
right.
about that particular population? Because they're still seeing you, they're still needing support. So if they choose not to have the procedure, then we can study something else about what brought them to see an IBCLC, and then what interventions that are non-surgical then lead to improved outcomes for that feeding team and that feeding dyad. So there's many questions you can ask and many things that can be studied. And even though the number of research studies has increased substantially over the last 2.5 decades, there's still so many questions to be asked and answered in this population.
Well, isn't that like the definition to me of good
Yeah,
research is it brings up more questions
absolutely.
to ask,
Yep.
right? So let's go back to quality of research and the idea that the only thing that matters is a randomized control study. I mean, because that's not
No.
true. Research is research, right? Evidence is evidence.
So yes and no. So I would say, the be all end all doesn't have to be the RCT, right? But we need to make sure that the studies that are being done, whether they're, convenience sampling, which most of it is at this point for this particular population, retrospective chart reviews, whatever the case may be in terms of the study, we just need to make sure that it's being done in a rigorous way and we're eliminating as much bias as possible. So, using the right statistical tests, choosing the right questions to ask, making sure you have enough people in the sample to adequately power the study. Those are all the things that will make research more robust, even if you're not doing an RCT.
Okay, great. So many of us in school, we had to take that research class, and at every level of my education, there was a little bit more of a research introduction, and it was not the favorite class of most nurses, right? So that and statistics, which kind of went along with
Right.
each other, right? So I'd love to know what brings you to research in itself and what brings you to this topic on research, because there's so many things as a nurse, so many directions you could have gone in.
Yes.
And this is a very specific role
It is.
and not an easy one as far as subject matter and not the easiest thing to do studies on, as we've just discussed. So
Yeah.
how'd you get here, Rebecca? What brought you to this place?
So it's so interesting. My nursing career as a registered nurse was in intensive care units and emergency departments, so very different. And I went back and got my master's and became a family nurse practitioner and went back to work in the emergency department as an FNP, but also in outpatient primary care. And at that point, I was really interested in diabetes research. Yes.
Wow.
Yep. And I've always loved research, right? So there's like a small percentage of us in nursing that do like those research classes and those statistics classes. I fell into that group.
Well, thank goodness there are people
It's
like you.
something for everyone in nursing, right?
Yeah.
Which is why it's such a great profession. So I went back for my DNP first, and I was working in rural, southeast state in a rural primary care practice. And I actually studied for my DNP. I was looking at the incidence of depression for patients with diabetes. And so I did that. I completed that program and said, what, I need more. I want to do, original research. I want to be making discoveries. And so I decided to pursue my PhD and applied to Boston College. I only applied to 2 schools for my PhD. BC was one of them. And from the time I applied to the time I actually started the program, I had my second child.
It's always motherhood that shifts us.
Yes. Yes. So I applied to that PhD program planning to study self-management of diabetes. And then I had my son, he'll be 9 in a couple weeks. And he had a tongue tie. And I didn't know he had a tongue tie. And
Because as I say all the time, we don't learn about this in
we
school.
don't.
Now here you are as a family nurse practitioner, right?
Right. So even better, I'm a family nurse
Yeah.
practitioner. I didn't learn about it in school. I had a tongue tie when I was born. And
Wow.
it was just snipped in the nursery, and that was the end of it. I'm not even sure they got consent from my mother to treat it. They just did it. And
Do you mind me asking, do you know if you were
I was
breastfed?
breastfed for 5 years.
Excellent. Well, that's why you're so smart, Rebecca. That's why you can do
I
this
had to
work.
thank my mom.
Good for her.
Yeah.
Wow.
So, and again, I'm a family nurse practitioner. I had a tongue tie myself, but I was in mom mode. I wasn't in nurse mode. I wasn't in nurse practitioner mode. I wasn't in any mode other than I have my second child. My oldest was only 14 months old. She wasn't even walking yet when my son was born. But all I knew was that I had an older child who didn't have an issue with feeding. And now I have this second child who who couldn't eat. He couldn't eat.
Right. So you know that there's
Right.
something is different here.
Exactly.
Something is wrong.
Exactly. He would,
Right.
regurgitate half of every feeding. He couldn't even barely eat out of a bottle, never mind on the breast. And he was miserable. So we were all miserable. And I was at the pediatrician probably daily. I mean, they probably thought I had Munchausen's, because I was like, there's something wrong. And, all they kept looking at was the
And
growth curve.
we don't trust mom's
Right.
instincts. This is
I
something that I'm
was,
preaching all the
yeah,
time.
I was,
It's so
and I
crazy.
had really good rapport with my pediatrician. They knew I was an
Right.
NP. My oldest was there. I kept going. I
Yeah.
kept
I'm
going.
sorry.
No, it's how it brought me here, and
Yeah.
I started doing my own research online, just Googling all of his symptoms. And I was in a mom group, a Facebook group of moms that all had kids around the same age. And one of the moms says, have you ever considered a tongue tie that's causing all these problems? And I was like, no. And so kept doing my own research and made an appointment for him to see a pediatric dentist 20 miles from my house. And she said, this is the most severe restriction he could have, right to the tip of the tongue.
Right.
At this point, he was 5 months old. It was the week of Thanksgiving.
Wow.
They lasered his tongue and his lip. And within 48 hours, most of his symptoms had resolved.
Wow. So N of one.
Yeah, an N of one, right? Anecdotal N of one.
Yeah. But let's go back. I just want to stop
Yeah.
you though, because your story is a story I hear daily. Yeah. And this is why I do what I do, right? Like this is absolutely why you're motivated as you're telling us. But it's very important not to, I'm not insulting other medical providers. I just think that it's ridiculous at this point that people aren't learning past their education in school. Like we shouldn't have to have a baby that teaches us this, right? We should have the support. And that's why I teach and my teaching is interdisciplinary because we have to reach everyone.
Right.
We have to reach everyone. We have to stop learning in silos and learn together, which is part of why we're both involved in the ICAP organization, right? We talked about that. That's where we met. I'm just sorry for you and for all the other stories of families that I hear on a daily basis that have gone through that.
Yeah, it's hard. And, going on these social media groups, again, it's all anecdotal, but the amount of people that are at their wits' end, like I was, to say, what is going on? What is the problem?
Right. And you mentioned like you started going down that rabbit hole on your own. And that's where I started too. Yeah. And I learned from a patient who said to me, somebody said maybe my baby has a tongue tie. And I was like, why? And I was already a lactation consultant. And she went and had the baby's tongue clipped and then came back to me and told me of how much better he was doing. And I saw how he was eating. And it was just, And at that time, it was just a scissor clip and an
Right.
ENT, and even that particular baby, that's all that child
Right.
needed, and he was good. And then I started like, let me really learn about this, because this is important. But it's so sad that that's where we have to be, and that's why what you're doing for the field is so admirable to me and to all of us in the trenches out here. So you have this baby, you're about to do diabetic research, which is wonderful in
Yes.
its own right, but totally unrelated. So how did you go to the school and say, guess what,
I did.
guys? I have another
I did.
plan.
So my academic advisor, she studied, chronic illness management in adults. And I said, first week of school, I said, so I'm going to change my path a little bit, and a lot, not a little bit, a lot. And I was very fortunate that there were 2 nurse researchers at Boston College that both study infant feeding. So I was able to, redirect my research to where my passion was and work with them very closely. And I've been very fortunate to be mentored by them and learn alongside them. So it was an easy transition, although, when you're looking at PhD programs, the whole point is to go somewhere where there's a faculty member that can teach you and guide you. So luckily there were.
But you're blazing your own trail.
Yeah.
As are most of us, right?
Yeah.
Like, I mean, I said this once recently, if you would have told me, I don't know, even 15 years ago, that in 2024, you'll have a podcast and your main focus will be tongue tie and you'll be teaching, I would have told you were crazy. I would have been like, yeah, right. I hadn't even given a presentation publicly, never mind speak every week on a podcast or have this focus. I was a midwife. I was catching babies, but this was the field that I knew needed my attention the most, like there's so many wonderful midwives doing wonderful things and teaching and all that. And I was like, I need to focus here. And I had to stop catching babies because you can't do this type of work and not sleep.
Right. Right. Yeah.
Right. So yeah, there was that. Plus I was getting on and, older and not bouncing back from those on calls so much.
Yeah.
But anyway, so Rebecca, so now it's a hard field. How has it been received? Like internally in the organization you were at, and then otherwise, like you must be part of like nursing, we said, you are a part of other nursing organizations. Is what you're doing respected? I hope it is.
Yeah.
But I mean, I would, in the nursing profession.
Yeah.
Okay.
I mean, I'm trying to be really cognizant of involving other health professions, disciplines in my research. We have to bring everyone into this to get the buy-in and to, disseminate research that spans a multitude of professions. It's not just nursing, it's not just speech, it's not just dentistry, it's all of them, because we're all interfacing with these patients in one way or another. So, I think, yes, it's definitely respected. And what's even more interesting is that when I start to tell someone new about what I do, they always know someone. Right? Every single person I talked to was like, oh, my granddaughter had that. My daughter was struggling so much. And it's like, yes, yep, exactly. So there's always someone knows someone that's dealt with a tongue tie, right? But then on the other side of that coin, there's still a lot, like you mentioned earlier, a lot of professionals in the various healthcare disciplines that still don't know about tongue tie. So it's an interesting kind of conundrum of someone that's experienced it, yet we haven't infused this into health professions education. We haven't created, an easy metric to identify the tongue tie or to make a decision to treat. So there's so much work to do.
And then also treatment varies, right?
Oh, yes.
Right. So there's so many different variables that could be here. And when I think about, like, from my point of view, and it's not a research point of view, it's a clinical point of view, I even think about like comparing apples and oranges, like, because not everyone does a frenotomy the same,
Right.
even with the same tool,
Right.
right?
Yep.
So, and not every parent is able to follow the same protocols. So even the protocols that we may think are ideal at this point, how do you test them if not you're not in the home with the parent? Like there's so many different
Mm-hmm.
variables. But this is why I feel like our clinical experience matters in this
Mm-hmm.
field. We need your
Right.
research. But I get angry when people, kind of downplay the clinical experience part of this, because the clinical experience is evidence in its own right,
Absolutely. Yeah.
you know?
And
And yeah. And the other thing about that is that, as you said before, all of these mothers on social media, we shouldn't use social media as
I
evidence,
know. I
but
know.
how could anyone say that this doesn't work and should never be done when you have so many people who have been helped by addressing it,
Right. Well,
right?
that's also
So
hard
it,
to measure too, though, right? Because you have
yeah,
all these
yeah,
people on social media saying, "Oh, my baby's tongue tie got better,"
right,
or no, my baby's feeding got better when the tongue tie was
right,
fixed. Well, that's
right.
fantastic. But what we still are only getting one piece of the story. Did they have
Mm-hmm.
lactation support? Did
Mm-hmm.
they see any other specialists at the same time that also helped? Because we certainly do see
Mm-hmm.
other folks that say we had the tongue tie fixed and nothing changed. So
Right,
that's
right.
kind of one of the big gaps right now is
Yeah.
to to understand from a research perspective who benefits most from this, and is it just the laser or the scissor that's giving us the greatest benefit, or do we need ancillary support,
Mm-hmm.
from lactation, from
Mm-hmm.
an SLP, from an OT?
Mm-hmm.
And I think people that work clinically can answer that question,
Yeah, yeah.
right?
And I also think that there's that variable of it's going to depend on the baby
Right,
too, right? Because not every baby is the same,
right, right.
right? So,
And what else is
or
going
has the same
on?
type of restrictions.
Right.
Like, just going on a clinical, whatever. I've been doing this for so long that I can look at a baby and say, in my experience, this baby should have either physical therapy or craniosacral or chiropractic, depending on the baby's body structure, how they stand, how they move, what I think that baby needs specifically, and guide them in that direction. But I don't know how to translate that into, well, because I see a right torticollis and a blah blah. That's not.
Right.
It's more of an experiential
Right.
judgment, and I have a conundrum of trying to teach that because that's hard,
Yes.
right? And I don't know if we'll ever have research that would actually do
No.
that, right? So I remember way back starting my first RN class, my first class in nursing school, we learned that nursing is an art and a
Mm-hmm.
science. I think that's all I remember from year one. That and how to talk to a patient when you walked in
Right.
a room, right? Which was
Right.
terrifying at the time, right? Hi, my name is Lisa, and I'm going to be your nurse today.
Right.
So, yeah. So it continues this art and
Mm-hmm.
science, right?
Yeah.
Like,
And clinical judgment. I mean, we're still clinical
yeah.
judgment as a nurse educator, like that is on the forefront of our minds always. Is, you can
Mm-hmm.
have students memorize things and regurgitate things, but they need the clinical judgment to know how to intervene, just as
Right,
you
right,
know, as a
right.
clinician, how to intervene and how to guide
Mm-hmm.
parents based on the years of time you've spent in that practice setting. So it's the same thing.
Mm-hmm.
And research will never capture all of that. And it's not intended
Mm-hmm.
to.
Mm-hmm.
Clinical judgment is critical for whatever
Mm-hmm.
discipline you practice in healthcare. Um,
Mm-hmm.
but what we also need is research to help bring the naysayers or those that are doubting any efficacy from a frenotomy. We need to bring them along. And the way to do that, because they may not ever do it in practice, right? They may never
Mm-hmm.
make the jump to starting to screen for oral restrictions. They just may not, which
Mm-hmm.
is,
Mm-hmm.
we can say that probably about any disorder or diagnosis. There are going to be providers that just don't include that in their repertoire.
Mm-hmm.
But if we can have some research out there that says, if the baby is experiencing X, Y, and Z, if the mother is experiencing A, B, and C, those together or those in isolation, consider referring them to someone that does have it in their repertoire.
Right. So know what you don't know.
Right. Exactly.
Which is what we do, right? I mean, in clinical practice, that's what we all do, right? I'm not doing everything myself. And, I am blessed to have a network of professionals in my area that I've cultivated over the years. And I know who does what best, and I would never pretend to, if I didn't understand something, I wouldn't say, oh, there's nothing wrong. That's what gets me more aggravated than them not assessing is don't pretend there's nothing wrong.
When the mom's coming every day to the pediatrician and saying there's something not right here.
Or making up something silly like, oh, it must be your nipples or your milk must be the wrong proportion of fat or something silly. Anyway.
Exactly. But that spans all disorders and diagnoses, so it's just about, you could compare it to diabetes, right? Someone could be diagnosed with type 1 insulin dependent diabetes and their primary care provider knows how to treat it based on the evidence, based on the research. They know that if this patient isn't treated with insulin, they will die, right? But maybe they don't feel comfortable prescribing insulin for a type 1 diabetes situation, and they refer it to an endocrinologist. But there's ample evidence out there to say, this is how you treat this type of patient. So we just need to get there for this type of patient.
Yeah. Now, I have an underlying feeling of the reason that it's like this for feeding in infants is because it's not a referral to another physician. So I feel like physicians are very comfortable referring to another physician. They're not as comfortable, at least in my experience, referring to a lactation consultant who's not a physician because they don't really understand what we do. And I don't blame them because, I know there's a lot of people that are born at a time when I say 1985, that sounds like ancient history, but it's really not. And that's when IBCLC was formed. So in medicine, 1985 was not that long ago. And it takes a long time to trickle down into medicine. And there is not always a lack of respect for non-physicians in medical training. I think it's getting better.
I do too.
I hope it's getting better.
Yeah, I think so.
But when I was training, it certainly wasn't, it was, I started at a time when I brought the doctor coffee. That was part of my job.
Oh, wow.
That's how, Yeah,
that's definitely changed.
Yes. But, they were also smoking in the living room. So, there's a lot of stuff has changed. For the better, for the worse, I don't know. But I think let's switch a little bit here because I want to hear I heard your presentation. I know about your research, but let's tell our audience a little bit about what you're working on now, the specific studies, so that we know what's coming down.
Yeah. So right now, you mentioned in the bio that I have grant funding from the Gerber Foundation. So I'm only the second nurse to ever be funded by that foundation, which was really exciting. And that funding, I'm using that to study the mechanics of breastfeeding, actually collecting sucking data while the baby is feeding at the breast and following them longitudinally over 2 months to collect that physiologic sucking data before they're treated and then 2 time points after they're treated for their tongue tie.
Wow.
And I also
are you doing sonograms with that?
No,
is that how
it's a transducer mechanism where it collects strength of suck, how many sucks per sucking burst, how long their breaks are for feeding. And I have, a group of babies that are diagnosed and treated for tongue tie, and then an age match sample of babies without tongue tie. So comparing, normal anatomy with the restricted anatomy to see what they look like. I'm also looking at growth. So the infant
Mm-hmm.
growth, doing weighted feeds as well, and evaluating symptoms of problematic feeding using the Infant Eat, which is a validated screening tool that the parent fills out, and including maternal anatomy as part of that as well.
Oh, beautiful.
So
That's
yeah,
great.
that was one of the big things in all the research that's out there that I think has been missing. So we are looking at pain with feeding, we're looking at milk transfer, we're looking at infant symptoms, but we have to include the maternal anatomy as a variable in that because
Mm-hmm.
and you probably know this better than I do, for some babies, if the mother's anatomy is adequate, they may breastfeed just fine. Um,
Mm-hmm.
but if you have that same restriction, that same baby, and the anatomy is not as conducive to latch, then they may not.
Right,
So
right.
that is
Yeah. I mean, translated, a woman with copious milk supply can feed,
right,
a baby can feed like a water
right,
fountain almost. And that was the experience of my own
right.
grandson. He had no, and those who listen to me have heard this story before. He couldn't suck on a
Yeah,
bottle.
that was my
If
son.
he had to be bottle fed, he would have been failure to
Mm,
thrive because he could not. And thank goodness my daughter's, had a great milk supply, especially in the beginning. It tapered
yeah,
down as there was lack of stimulation, as it usually does, but she had an amazing milk supply and he gains beautifully, but he had oral restrictions and other structural things going on in his mouth and
yeah,
his, it wasn't just a simple clip for my
right.
grandson. Of course, not my grandson, right? He is a case study, in himself. But so the anatomy, doing that arm of looking at that for research is vital because as I have a whole presentation, addressing maternal issues and letting people realize that they forget that this is a
Right,
dyad. This isn't just about that
right,
baby.
right. And
Yeah.
interestingly enough, though, most of the research is on the mother. So
Okay.
most of the research that has been published in the last 2.5 decades is on the mother in terms of nipple
Mm-hmm.
pain,
Mm-hmm.
discomfort, emptying of the breast. So we're missing some of the infant stuff. So that's
Mm-hmm.
where,
Okay.
like you said, it is a dyad. We're treating the baby. So we need some infant
Mm-hmm.
data as well as the
Mm-hmm.
maternal data. And,
Mm-hmm.
we can't forget about babies that are bottle fed. So that's,
Mm-hmm.
obviously a much lower number of research publications that's out there is focusing on bottle feeding. But we know
Mm-hmm.
that, the vast majority of babies are not breastfed. So what's happening with
Mm-hmm.
them? And that is an important area of research that needs to be
Yeah.
included moving forward.
Yeah. The aspect of maternal pain, I've seen those studies backfire in criticism. So there was an article in a well-known newspaper who will remain nameless on this podcast.
Good idea.
I've mentioned it when it happened, but I'm not giving it anymore, whatever. But when I was reading the responses and the editorial comments, there was a lot of, well, the only reason why you would do that is for the mother's comfort, and that was selfish.
Mm,
And so many people thought
interesting.
that it was selfish to quote unquote fix the baby or do something to the baby just so the mother could be comfortable breastfeeding.
Right.
Which, where are we in our society
Right.
if there are people saying that? Like, I don't
Well,
even know. I wished I hadn't read these
I
comments,
know.
but that sticks in my mind because that's because there is research saying that frenotomy prevents or decreases maternal nipple
Right.
pain.
I mean, to be fair, Lisa, there's still people being asked to breastfeed in bathroom stalls. So,
I know.
that's where
I
we are in
know.
society. But
Yeah. What a
if
shame.
mothers want to breastfeed, they should be able to.
Exactly. And comfortably.
Right.
Comfortably.
Right. It's not supposed to hurt
It's not supposed
once
to
a
hurt.
month a
It's not
month.
supposed to be a
Right.
struggle. You shouldn't have to worry about your baby surviving. They should be thriving. And it should be, the postpartum period should be a wonderful time.
Yeah.
And for some, it's not so wonderful. Anyway, but again, I am so excited to hear about your research, to follow it. For those of, I will put your links in the show notes for those, but some people never get to actually look at the show notes. So tell us, where is the best place to follow what you're doing? Is there a website where we could see your research, or is there a particular journal to follow you through?
So journals are kind of all over the place, but ResearchGate, I'm on ResearchGate.
Okay,
All of my
great.
publications are there. And if anyone would like to request a full text, they can just shoot me a message on there and I can send it via email. So most of them are not
Excellent.
open access because you have to pay lots of
Mm-hmm.
money to have everything open access.
Yes,
But I
yes.
can share, the full text of any article for anyone that's interested in reading.
Okay, Rebecca. And just before we go, I just wanted to ask you if there was one thing you wanted people to know about your work, what would it be?
One thing.
About your, what you found, or what things are showing, or what insights you've learned.
Yeah. So it's such an interesting question. One thing, oh my gosh. I mean, I guess the one thing overarching all of the research is that you need to listen to the patient or listen to the parent or the caregiver. If they're feeling that something is askew, take that, and if you don't know what to do, find someone who does.
Excellent. Thank you.
Thank you.
Thank you for that.
Yes.
I know that was a tough question, and that was a wonderful answer. Thank you for the work you do, and I hope we talk again
Yes. Thank
soon.
you so much for having me.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue-tie Experts Insiders. It includes monthly online meetups with me, Lisa Palladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue-tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.